This is the lecture for the first part of abnormal psychology, which focuses on four distinct abnormal disorder types, which are mood disorder, psychotic disorder, dissociative disorders, and impulse control disorders. When we talk about uh, the diagnosis of and looking at psychological disorders and mental illness, psychologists fall under a process called the medical model. And the medical model basically says that when somebody has a problem, whether it be physical or mental, they go and see a specialist for treatment. And that can include a psychologist or a psychiatrist. And based on their symptoms, sometimes it's described, and sometimes it can be seen with different forms of computerized devices. But with their symptoms, then they receive treatment. And this model, which we experience all the time when we go to the doctor, is the same kind of model that we experience when diagnosing and treating mental illness. Now, why does mental illness happen? Well, mental illness happens because of a biopsychosocial approach, which, if you remember from before, says that there are three distinct sets of influences that will affect why a person feels or acts the way that they do. With psychological disorders, it's no different. Biological influences can include things like genetics or abnormal amounts of neurotransmitters or hormones or undersized or oversized parts of the brain. Psychological influences can include negative thoughts, stress, as negative thinking and negative learned behaviors. And then finally, sociocultural influences can include uh, problems brought on by people in people's families, problems brought on by society. And so all three of these things play a role in the development of different mental illnesses. Some mental illnesses will be more heavier on one of these three than others, but all have influences from all three. The main manual that we use to diagnose and determine mental illness is the DSM. The DSM stands for the Diagnostic and Statistical Manual for Mental Disorders. And we are currently in the fifth edition. Now, every 10 to 15 years, a new edition comes out to reflect the changing ideas and understanding of mental illness at the time. For example, it wasn't until the third DSM that homosexuality was taken out of the DSM because it was not classified as a mental disorder anymore. Obviously, the DSM and the medical model look to provide labels, and this can be important because the benefits to labels is that once somebody is diagnosed with something, they can get a specific form of treatment that's designed to really work to help the person with that issue. But obviously, there are some problems with labels too. Sometimes when people are labeled with mental illness, they experience different sort of perception from the people that they care about, along with also doctors too. Doctors can, as we saw with the David Rosenhan experiment, doctors may attribute a person's behavior to their mental illness just because they've been labeled with it. We're going to start off talking about mood disorders. So, with mood disorders, there are some specific characteristics that we see. The first are behavioral or cognitive changes that accompany mood disorders. And when we're talking about mood disorders, we're primarily talking about depressive disorders. Uh, People who begin to experience mood disorders may feel alone or empty. They might expect negative outcomes. And when trying to interact with people, they may try to avoid interaction because they're just expecting that negative outcome. Oftentimes, mood disorders are brought on by stressful events related to work or marriage or close relationships. Uh, the depression is a response to past and current stress. Certainly, childhood stress, but also present stress can play a huge role in the development of mood disorders. Depression also runs in family, however. We see that um, if a parent or a sibling has a mood disorder, then other people in the family are at higher risk for having a mood disorder. They may not get one, but they're at much higher risk. Another characteristic of mood disorders is rumination, and rumination is when people overthink things. This is one of the key characteristics of depression, as people tend to uh, have this negative idea and self-focused kind of sets of thoughts, which people are trying to stay in control. So they're trying to think of every possible thing that can occur, but in the process, they are making themselves feel worse. Another characteristic of mood disorders is negative explanatory style. Negative explanatory style is uh, basically how people with mood disorders will potentially explain the bad things that happen to them, because everybody experiences bad things. But when you have a mood disorder, oftentimes this explanatory style can attribute to the worsening and the feeling of that mood. A stable explanatory style would be something like, um, if you break up with a romantic partner, then a stable one would be like, I'll never get over this. This will never get better. Um, a global negative explanatory style is one in which a person feels like things are hopeless. Um, when they break up with that person, without that person, I can't do anything right. Uh, and then finally, they also have an internal explanatory style, which is basically assigning blame to themselves for everything. This was all my fault. I'm the cause of all the problems that are happening. And when people have that negative explanatory style, uh, then oftentimes that can lead to worse depression. And the problem with depression is that depression itself is a cycle. Depression itself goes through a cycle starting off with stressful experiences, followed by the negative explanation of those experiences, which leads someone to feel depressed, which changes their thinking and changes their behavior, which causes them to experience more stress. And the process repeats itself over and over and over again, and is very difficult to escape. So, what is depression? Well, everybody experiences depression, and depression itself is just feeling sad. It's feeling sad as a result of something that has occurred. Sometimes that can be imagined, and oftentimes it is real. But for people who have depression with mood disorders, the depression lingers, it doesn't go away. While we all experience depression at one point or another, people who experience a depressive disorder or a mood disorder will experience long term feelings of depression. For example, in dysthymia, which is a persistent depressive disorder, uh, patients may experience problems with appetite or sleep or energy or self esteem or concentrations or feelings of hopelessness. And if they experience at least two that last over 2 months, then they can be diagnosed with dysthymia. Major depressive disorder is when the depression becomes extreme. And this can include at least 5 symptoms that last 2 or more weeks straight. And you can see the list of everything that makes up those different systems: depression, depressed mood, no interest in pleasures, problems with eating, like too much or too little, problems with sleeping, too much or too little, either being very physically agitated, like you can't sit still, or lethargic, like you can't move. Uh, Problems with thinking, concentrations, decisions, worthless and guilty feelings, lacking energy, and then suicidal thoughts. Unfortunately, mood disorders, especially major depressive disorders, are some of the prime contributors to suicide that people go through when they experience it. Another mood disorder is seasonal affective disorder. Seasonal affective disorder says that we feel a depressed mood when we're in the winter months. And this is most likely due to the idea that we're not getting as much sunlight. You may remember that uh, sunlight spurs the stopping of melatonin, and when melatonin levels are too high because there isn't so much sunlight, and you especially see this in places like within very northern latitudes like Russia or Alaska, then without that sunlight, people begin to not get the serotonin they need, which will then, of course, raise their mood. Bipolar disorder is a very tricky disorder. Bipolar disorder is a mood disorder that has two phases. In bipolar disorder, a person will swing back and forth and have really, really dramatic mood swings from both these two phases, the manic phase and the depressive phase. In the manic phase, a person may have incredible amounts of energy, incredible amounts of enthusiasm, and incredible amounts of just new ideas as well. But they can very quickly swing to a depressive state. Now, all of us have mood swings, but if we're going to put our mood on a scale of 1 to 10, most of us kind of have a mood swing that goes from about 4 to 7, maybe. With bipolar disorder, it's much more dramatic, more like a 1 to a 10 or a 10 to a 1. The primary trigger that causes the shift in mood with people with the bipolar disorder is stress, as well as lack of sleep as well, can affect how people's moods shift back and forth. There is a more milder version of bipolar disorder called cyclothymia. And cyclothymia would be basically like, if we were to take that number scale again, someone that goes from 2 or 3 to about an 8, and then back and forth. But it's essentially a more mild version of bipolar disorder. Then we move on to psychotic disorders. Psychotic disorders are disorders in which a person experiences psychosis or a loss of touch with reality. There are some pretty distinct characteristics of psychotic disorders, which the primary psychotic disorder is schizophrenia. The first is hallucinations. Hallucinations is experiencing something sensory, perceiving something sensory that's not there, that is created in the mind. This can be a sight, it could be a sound, it could be a taste even, or a smell. With schizophrenia, the primary one that's seen is auditory hallucinations. Delusions are another characteristic of psychotic disorders. And with delusions, it's when people feel like there's something that they're not. Like they feel like they're dying, or they feel like they're extremely lucky or a perfect person in any way, or they may have gross delusions in which they may feel like they're living another life. Disorganized thinking is when a person's thought and speech, especially, shift from one topic to another and to another and to another very quickly and without any sort of reference. When this is seen in speech, it sometimes even can come out as incoherence. Grossly disorganized behavior is the extreme behaviors that are seen with people with psychotic disorders. And that can be anything from childlike silliness to agitation, extreme physical agitation, to being catatonic, in which a person won't move and won't talk. And finally, there's also negative symptoms. And negative symptoms means that essentially a person experiences less of symptoms that are essentially normal. So less emotions, or less motivation, or less pleasure, or less sociability. Schizophrenia is the prime example of the psychotic disorders. Schizophrenia itself manifests somewhere between the late teens to the early 30s. With schizophrenia, there are both positive and negative symptoms. Negative symptoms, which we went over already, are when a person experiences less of symptoms that they might normally have. Positive symptoms are when symptoms are added that they shouldn't have, like hallucinations or delusions. What's the cause of schizophrenia? Well, the cause is essentially a combination of genetics and an environment. There isn't one gene that's associated with schizophrenia, but a many number of genes that environmental effects can trigger and cause to manifest. So what kinds of things does this do to a person that contributes to this? What kind of things may contribute to a development? Well, one of the biggest things that we see is that a person has too much dopamine. when there's an overabundance of dopamine that can cause and trigger hallucinations and delusions. Sometimes it's smaller than normal portions of the brain, like the corpus callosum or the hippocampus. And in some cases, it may be part of prenatal development, in which a mother experienced a flu infection while pregnant, and that can cause an increased risk. But it's not just the environmental effects, and it's not just the genetics. It's a combination of both. Dissociative disorders are disorders in which a person experiences such a trauma, such a environmental trauma, that their mind essentially splits. And in some cases, when it splits, the new portion that is, manifested can do very unusual things. These are very, very rare disorders, but they do happen. The most common of the three is dissociative amnesia. Dissociative amnesia starts with traumatic events. Uh, this could be physical abuse, sexual abuse, emotional abuse, or all three. When that occurs, the person who experiences it will literally create a portion of their mind that has completely repressed the memory and completely forgotten about that traumatic event. We have talked about before that memory repression is really, really rare, but in the case of dissociative amnesia, it does occur. With dissociative fugue, you add in an additional portion. And with dissociative fugue, a person not only experiences the amnesia where they forget about the trauma, but it also causes them to literally physically try to escape and run away. And so when a person regains kind of somewhat normal consciousness, they will be in a place that they don't know where they are, and they won't know who they are because the amnesia will have blocked all the memories. And this is essentially both a mental and physical escape from the conflict or the anxiety that's caused by the trauma. Now, maybe the one that's kind of most known in pop culture, but is probably the rarest, is dissociative identity disorder. Dissociative identity disorder, a person's mind will split, and rather than having one portion which just forgets, they have the new portion or portions will be designed to deal with the trauma. And essentially, this will create an additional personality. And so people with dissociative identity disorder will have multiple personalities. Sometimes these personalities will be a different gender. Oftentimes, there will be different races. In some cases, there'll even be a different language that's spoken. And it's a way for the individual to distance themselves from anxiety and create a persona that can deal with some of the trauma that comes from the anxiety. Finally, we get to impulse control disorders. So impulses are when we want something that we know we shouldn't want, or we want to do something that we know we shouldn't do. Oftentimes, we can ignore these impulses. Sometimes we give in. And when it's an impulse control disorder, a person consistently will give in, maybe not every time, but will give in to those impulses all along. Some people have classified drug addiction as an impulse control disorder because, along with the physical withdrawal symptoms that a person goes through, it's that habituation and the needing to have the drug to feel normal that causes a person to give into that impulse. With impulse control disorders, there are 5 behavioral stages. The first is the impulse itself, the feeling of needing to do something. Oftentimes, it's not acted on initially. However, then because it's not acted on initially, that impulse, the tension related to that impulse grows and grows and grows. A person will then finally give in and experience that impulsive behavior, and then will experience pleasure and relief at the same time. Pleasure from acting on that impulse, this is what they wanted to do, and relief from the elimination of the tension from the urge. But a lot of times these behaviors are self-destructive, and that usually comes along with guilt for some people. Not all people, but for some people it definitely does. And that guilt then can cause a person to experience things like anxiety or depression as a result of that impulse control disorder. And that may stop it. That 5 behavioral stages may stop it for a long period of time. It may go dormant, but then that impulse can come back. And when that impulse can come back, a person with an impulse control disorder will go through those 5 stages again and again and again. There are 3 distinct impulse control disorders that we definitely need to cover. The first is pyromania. Pyromania is when a person has an uncontrollable impulse to set fires. Obviously, the potential for destruction of property, the potential for loss of life or severe injury of other people is extremely high. Pyromania is probably the most dangerous of all the impulse control disorders. Kleptomania is when a person can't stop themselves from stealing. Oftentimes, people with kleptomania won't steal very expensive items because it's not about the expense of the item that they want to steal. It's about the process and the behavior of stealing that they can't stop themselves from doing. Obviously, this can lead to many problems at home, problems with the law, and so on. And finally, then there's pathological gambling disorder. And pathological gambling disorder is when a person can't stop that impulse to keep gambling and to keep putting down money. They always feel like the next time they do it is the time that they're going to win. So they can't stop themselves, even though they know that it might be self-destructive. This can create a lot of problems in families because obviously this can cause a person to go through their life savings so that they won't have enough money to feed their family or to pay a rent or a mortgage, and certainly can cause a lot of family stress as a result. And this is where we go ahead and stop.